Right now, leading aesthetic clinics are treating these severe, painful symptoms of menopause, not with hormones, but with the highly purified DNA of freshwater trout.
I know, it sounds completely like science fiction.
It really does.
Yeah.
But it is actually the bleeding edge of regenerative medicine. So today, we are analyzing a topic that is gaining massive traction across the medical field, which is intimate polynucleotide therapy.
Yeah, and our sources for this deep dive are incredibly dense. I mean, we have got clinical trial data, technical medical blogs from top aesthetic clinics, and comprehensive women's health protocols.
Right. And our mission today is to cut through all that medical jargon. We want to uncover exactly what intimate polynucleotide therapy is, the underlying cellular mechanics of how it actually works, and whether the clinical evidence matches the immense hype surrounding regenerative women's health.
Because there is a lot of hype right now, for sure.
Exactly. So if you are navigating these hormonal shifts yourself, or supporting a partner who is, or honestly, if you are just fascinated by the rapid evolution of biotechnology, this deep dive is going to fundamentally change how you view tissue repair. Okay, let's unpack this.
Well, to really understand the utility of animal-derived DNA in this context, we first have to establish the sheer scale of the biological problem.
Right, the reason this therapy was even invented.
Exactly. In the medical community, we refer to it as Genitourinary Syndrome of Menopause, or GSM, and that encompasses vulvovaginal atrophy.
Which sounds intense.
It is. We are talking about a dramatic structural collapse of the vulvovaginal tissues when estrogen levels plummet. That could be from natural menopause, surgical interventions, or even chemotherapy.
And the numbers in our sources are just staggering. I mean, the Women's Empower survey data shows this affects 50 to 70% of postmenopausal women.
Yeah, the majority. And the symptoms are relentless.
Right, like chronic dryness, intense itching.
Yes, and micro tears in the mucosa, plus dyspareunia, which is painful intercourse.
And yet, despite all of that suffering, the same survey reveals an unacceptable treatment gap. Up to 50% of women suffering from GSM never receive any medical intervention.
It's half of them.
Yeah, half of them are just living with this tissue degradation basically in silence.
Which is awful because the standard of care has historically been localized hormone replacement therapy. You know, low-dose estrogen applied directly to the mucosa to artificially maintain that tissue vitality.
But not everyone can take hormones.
Right. A vast demographic of patients cannot utilize that pathway. Hormone receptor-positive breast cancer survivors, for instance, are strictly advised against it. And a significant portion of the patient population simply opts out of hormonal interventions due to personal preference or worries about side effects.
Which leaves a massive void for effective structural interventions for these women.
It does.
But that actually brings us to a really fascinating biological tension. I mean, if the fundamental root cause of this structural damage is a lack of estrogen, a non-hormonal treatment seems, well, counterintuitive.
It does sound like a contradiction at first.
Right. If the signaling molecule that tells the tissue to stay thick, hydrated, and elastic is just gone, how do you rebuild the architecture without replacing the signal? It feels like trying to run an engine without oil and just hoping a new type of metal will prevent the friction.
That is a great analogy, but if we connect this to the bigger picture, we are actually looking at a massive paradigm shift in regenerative medicine here.
Okay, how so?
We are moving away from hormone replacement and toward direct cellular signaling. Estrogen is really just one key that turns the ignition on tissue maintenance.
Right.
So if that key is missing, biotechnology asks a new question. Can we hotwire the car?
Oh, wow.
Yeah, can we bypass the hormonal pathway entirely and send a different, equally potent signal directly to the cellular repair mechanisms?
Enter the polynucleotides.
Exactly.
So our sources define polynucleotides as highly purified fragments of natural DNA, typically extracted from the sperm cells of ethically bred freshwater fish.
Specifically Italian trout or salmon.
Right. But my immediate thought reading this was about the mechanism. How does fish DNA effectively hotwire a human cellular engine without causing a complete biological misfire?
Well, the secret lies in a concept called spectral compatibility.
Spectral compatibility, okay.
Yeah. The nucleic acid-based pairs in these specific fish are arranged in a molecular sequence that is highly recognized by human cellular receptors.
So they match up.
Exactly. When these DNA fragments are introduced into human tissue, they don't just act as a passive dermal filler, they operate as active biological messengers. They specifically seek out and bind to adenosine receptors, predominantly the A2A receptors, which are located on the surface of fibroblasts.
Wait, because fibroblasts are the primary architects of the extracellular matrix, right?
They got it.
They are the factories responsible for synthesizing collagen and elastin. So by binding to these A2A receptors, the polynucleotides are essentially rewriting the software instructions of the cell.
Yeah.
They're forcing the fibroblast into an active proliferative state without actually needing estrogen to give the order.
That is the exact mechanism. Activating those adenosine receptors triggers a profound intracellular cascade. The fibroblasts rapidly upregulate the production of collagen types I and II, as well as elastin, and that physically rebuilds the lost structural integrity of the mucosa.
That is incredible.
And it gets better. Furthermore, this interaction stimulates the release of vascular endothelial growth factor, or VEGF.
Oh, which triggers angiogenesis.
Exactly. The localized formation of brand new micro blood vessels branching off from the existing vascular network.
Well, that makes perfect sense for GSM because atrophy severely diminishes localized blood flow.
It basically starves the tissue.
Right, so by forcing the creation of new capillaries, you are restoring the oxygen and nutrient delivery pipeline that the tissue desperately needs to actually sustain this newly synthesized collagen.
Precisely.
But wait, injecting exogenous DNA into the highly vascularized sensitive mucosa raises a major red flag for me regarding immunogenicity.
Sure, the allergy risk.
Yeah, I mean, if we are introducing foreign genetic material from a marine animal, I would totally expect the human immune system to instantly recognize it as a pathogen and mount a severe inflammatory response. Yeah, total rejection.
And the safety profile is heavily scrutinized in our clinical sources for that exact reason. But the reason this therapy bypasses the immune system comes down to the extreme purification protocols.
Okay.
Masnelli, which is the company holding the patent on PNHPT, and that stands for highly purified technology, utilizes an extraction process involving extreme temperatures.
So they bake it out.
Essentially, yes. This process completely denatures and strips away all proteins and peptides from the original source material.
Leaving only the naked nucleic acid backbone.
Exactly.
And since proteins are the primary antigens that trigger an allergic or immune cascade, removing them renders the substance virtually non-immunogenic.
Right. The immune system simply doesn't recognize the purified DNA fragment as an invading threat at all.
Though I did note, the medical guidelines maintain a strict precaution that individuals with known severe fish allergies should still avoid the treatment.
Yeah, absolutely. Clinical caution always dictates avoiding known allergens, even when the allergenic proteins have ostensibly been removed. It is simply a redundant safety measure.
That makes sense. Now, if we look closely at the formulation data, clinics aren't just injecting these isolated polynucleotides by themselves, right?
No, they are not.
Products highlighted in our sources like Nugen and Cineco's Intercare utilize a highly specific triple-action synergy.
Yes, a very specific blend.
They're suspending these DNA fragments in a matrix containing hyaluronic acid, alongside an ingredient like mannitol, or a specific blend of amino acids.
Right.
And since we know the polynucleotides are acting as the cellular signaling mechanism, I imagine the hyaluronic acid is acting as the immediate hydration reservoir. I mean, given its capacity to bind massive amounts of water.
It acts like a giant sponge, exactly.
But the inclusion of mannitol in the mucosal environment is incredibly strategic from what I read.
It really is. Mannitol's role is entirely protective. You see, in menopausal tissue, the physiological environment is often highly oxidative.
Okay.
And the body naturally produces hyaluronidases, which are enzymes that aggressively break down endogenous and exogenous hyaluronic acid.
Ah, so mannitol is acting as a molecular decoy.
Exactly.
It neutralizes the reactive oxygen species and essentially distracts those degrading enzymes, which allows the hyaluronic acid to remain stable within the tissue for a significantly extended period.
Yes.
So if I use an analogy here, the polynucleotides are the construction workers building new tissue, the hyaluronic acid is the sponge holding all the deep moisture, and the mannitol is the security guard protecting the sponge from being broken down.
That is a perfect way to visualize it. It shields the hydration reservoir while the polynucleotides take their time signaling the fibroblasts to rebuild the foundational architecture.
Wow.
And that sequential synergy is vital because tissue remodeling is not instantaneous. Fibroblast activation and the subsequent kinetics of collagen synthesis require weeks to properly mature.
which dictates the clinical procedure and the timeline.
Right.
Because this relies on proximity to the fibroblasts. You can't just inject this systemically into the arm or something. You have to be highly strategic.
Very localized.
The clinician utilizes a very fine 30-gauge needle to place this gel-like matrix directly into the failing mucosal architecture.
After applying a numbing cream, of course.
Good point.
Wow.
And we are talking about targeted micro-injections into the vestibule, the introitus, and the lower third of the vaginal wall, utilizing techniques like linear retrograde threads and microwheels to ensure even distribution.
Yeah, across all the damaged mucosa. And setting patient expectations regarding the timeline is critical here. It is not a one-and-done fix.
Right. How many sessions are we talking?
Well, the established protocol requires an initial priming cycle. This typically involves 3 to 6 separate clinical sessions, spaced roughly 2 to 3 weeks apart.
Okay, so it takes a couple of months.
It does. This repeated exposure is absolutely necessary to sustain the continuous activation of the adenosine receptors.
And then what happens after that cycle?
Once the tissue architecture has been regenerated, the protocol shifts to a maintenance phase. That requires follow-up treatments every 6 to 12 months, heavily dependent on the patient's biological baseline and the initial severity of the atrophy.
I have to say, subjecting a patient to multiple injection sessions in a highly compromised hypersensitive area is a significant clinical undertaking.
It is not trivial.
So the evidence really needs to be robust to justify putting a patient through that process. Diving into the studies provided, we have the 2019 exploratory study focusing on 19 postmenopausal women, and then the more recent multi-center study published in the MDPI journal observing 84 women.
Yes, those are key studies.
And the clinical metrics they track, like the Vaginal Health Index and the Visual Analog Scale for Pain, showed pretty remarkable trajectories.
They did. The data demonstrated rapid and statistically significant improvements across almost all measured parameters. Oh, absolutely. Within months of initiating the priming cycle, clinical scores tracking mucosal elasticity, fluid volume, and epithelial integrity basically skyrocketed. Wow. Conversely, the severity scores for chronic itching, burning, and dyspareunia plummeted. I mean, fundamentally altering the patient's day-to-day comfort.
And one of the aesthetic clinic blogs provided a patient case study that really grounds these clinical metrics in reality.
Right. The story about Elizabeth.
Yeah, Elizabeth. She presented with such severe atrophy that conventional therapies, including prescribed local estrogen and testosterone creams, completely failed to arrest the symptoms.
They just weren't enough.
No. Her mucosal tissue was so degraded she was waking up in the night, subconsciously scratching until she bled.
Oh.
I mean, her sleep architecture and overall quality of life were just decimated.
It is heartbreaking to read.
But the case notes indicate that after just 2 to 3 sessions of targeted polynucleotide therapy, her tissue architecture stabilized enough that the relentless pruritus, the itching, finally subsided.
She was sleeping through the night again.
Yeah. And clinical examination showed a visible restoration of mucosal health.
Cases like Elizabeth's really underscore the limitations of our current pharmacological toolkit.
Yeah.
You know, when tissue degradation outpaces the regenerative capacity of topical hormones, introducing a direct biostimulatory signal can salvage the mucosal lining in ways traditional medicine currently struggles to replicate.
Look, if the cells are physically changing and symptoms are resolving this dramatically, it sounds incredibly promising. But as we analyze emerging therapies, we have to maintain rigorous skepticism here.
Absolutely, we always need to look at the limitations.
Because procedural interventions for genitourinary syndrome of menopause, particularly those involving intimate injections, are notorious for a remarkably high placebo response rate. I saw it cited between 30 and 50% in one of our sources.
Is a massive variable.
Right. The psychological impact of receiving dedicated hands-on care from a specialist for a highly intimate issue can drastically alter a patient's subjective perception of pain. So, without large-scale, double-blind, randomized controlled trials, which are inherently difficult to design for injectables, how can we definitively separate the biological efficacy of the polynucleotides from this massive psychological placebo effect?
Well, what's fascinating here is the reliance on objective histological markers to counter that exact skepticism.
Objective markers, like what?
So, subjective pain scales are highly vulnerable to the placebo effect, but cellular maturation is not. In these studies, clinicians are utilizing the vaginal maturation index. They're taking vertical swabs of the vaginal wall and analyzing the cellular composition under a microscope.
Oh, right, looking for the ratio of peribasal to superficial cells.
Exactly. Atrophic tissue is dominated by unhealthy, immature peribasal cells. But post-treatment biopsies demonstrate a profound histological shift, showing a dense population of healthy, mature, superficial cells.
You can't placebo your way into new cells.
No, you can't. Furthermore, they are tracking the vaginal pH.
Okay, how does that work?
The newly matured epithelial cells are rich in glycogen. When these cells naturally shed, the glycogen feeds the local lactobacilli in the biome.
Uh-huh.
Those bacteria metabolize it into lactic acid, which drives the vaginal pH back down into a healthy acidic range.
Wow.
A placebo effect might make a patient feel more comfortable subjectively, but a psychological response cannot spontaneously induce the production of glycogen, alter the cellular maturation index, or physically lower the pH of the vaginal biome.
That histological evidence is the crucial differentiator then.
Yeah.
We're seeing verifiable structural remodeling, not just pain management.
Exactly.
But, biology is rarely a silver bullet. If this therapy forces cellular machinery into overdrive, there have to be scenarios where we explicitly do not want to trigger that kind of rapid proliferation.
Oh, definitely.
Analyzing the contraindications, the medical guidelines are incredibly strict regarding who is excluded from this treatment pool.
Safety protocols demand an absolute exclusion of any patient with an active localized infection. I mean, you cannot introduce a biostimulator into an environment currently battling a urinary tract infection, candidiasis, or bacterial vaginosis.
The infection would just flare up.
The inflammation must be fully resolved first, yes. More critically, any patient presenting with unexplained postmenopausal bleeding is immediately disqualified until they have undergone a comprehensive gynecological workup.
Because of the cancer risk.
Right. Biostimulators promote angiogenesis and cellular proliferation. If there is an undiagnosed mucosal malignancy, upregulating local blood flow and cellular activity is biologically dangerous.
That makes total sense.
Additionally, patients managing severe autoimmune conditions or those on aggressive anticoagulant therapies face elevated risks of poor healing and severe hematomas.
Good to know. Also, the leading women's health clinics in our stack emphasize the current hierarchy of evidence. While the histological shifts are compelling, they transparently categorize the evidence for polynucleotides as emerging but limited.
Yes, that is the official stance.
Especially when you contrast it with the decades of Cochrane-reviewed data supporting low-dose local estrogen. They also frequently compare polynucleotides to platelet-rich plasma, or PRP, which is commonly commercialized as the O-shot in intimate aesthetics.
Right, the O-shot is quite well known.
But while both are regenerative, PRP harvests endogenous growth factors from the patient's own spun-down blood, whereas polynucleotides introduce an exogenous DNA signal from the fish.
Correct.
Yet, the consensus categorizes both PRP and polynucleotides as adjunct therapies.
And that categorization is vital for clinical strategy. Regenerative medicine should never be deployed as the first line of defense for GSM. Treatment algorithms dictate a sequential approach.
Right. So if you are staring at these emerging studies and wondering where this fits into your own treatment plan, or if you should seek it out now, the strategy is all about foundational optimization first.
Yes, start with the basics.
The clinical consensus mandates, starting with evidence-backed basics, establishing a rigorous routine with high-quality, osmolar balanced vaginal moisturizers to restore baseline hydration, utilizing appropriate silicone-based lubricants during intimacy to mitigate mechanical microtrauma.
Right, protective measures.
And if you are a viable candidate, exploring localized low-dose estrogen or DHEA. You really have to stabilize the environment first.
Absolutely. If a patient rigorously adheres to those foundational therapies and still experiences recalcitrant localized pain, perhaps severe stinging at the vestibule or mucosal fissures that refuse to heal,
Then what?
well, that is the precise clinical window where an adjunctive targeted biostimulator like polynucleotides becomes a highly rational intervention to discuss with a regenerative specialist.
So what does this all mean? It is a specialized tool for structural repair, deployed when the foundational maintenance fails. The trajectory of this deep dive has been just remarkable. We began with the systemic, deeply ignored crisis of genitourinary syndrome of menopause. Basically a condition leaving millions of women silently managing the collapse of their intimate tissue architecture.
It really is a silent struggle for so many.
And we ended at the microscopic level, decoding how highly purified trout DNA can actually hijack human adenosine receptors, acting as a profound biological messenger to restart stalled collagen synthesis and trigger the growth of new vascular networks.
And the ultimate takeaway here is the power of biological literacy. Understanding the intricate mechanisms of these novel, non-hormonal therapies empowers patients to advocate for comprehensive care.
Yeah, knowledge really is power.
It fundamentally challenges the antiquated notion that enduring structural degradation and intimate pain is simply an inevitable consequence of aging. You don't have to just live with it. The regenerative toolkit is expanding rapidly. Understanding the cellular science behind options like polynucleotides allows patients to engage in highly proactive, informed strategy sessions with their healthcare providers.
Demand more from your medical care than simply managing the decline, right?
Exactly.
But as we close this analysis, I want to leave you with a final thought to ponder regarding the trajectory of this science. Throughout this deep dive, we have examined the use of animal-derived DNA fragments purely as a reactive measure. We are deploying them to restore human tissue back to a functional baseline only after the biological clock has wound down and the damage has already occurred.
Yes, as a repair mechanism.
But as this biotechnology continues to refine its precision, and as we decode even more complex cellular signaling pathways, we have to ask, will we eventually utilize these very same polynucleotide mechanisms, not just to heal the downstream effects of aging, but to fundamentally rewrite the software of how our mucosal cells experience the aging process in the first place?
That is the frontier.
If we can successfully program a human cell to rebuild a shattered foundation today, what complex biological behaviors will we be able to code tomorrow? Something to think about.